Bismillah Rahman Rahim. For today's session, we have invited Dr. Akifullah Khan, who is a nuclear physician. He has done his FRCP. He has done his MS in nuclear medicine. He is working currently as a director at Peshawar, and he is president Society of Nuclear Medicine at Pakistan. He has got more than 60 publication on his credit, and he is his subject of choice is nuclear medicine, of course, thyroid cancer management, and thyroid related problems. So we welcome you on this session, sir. And today, for this host for this session would be Dr. Maria Mirjan and Dr. Maham Kazi as usual. Participants from across the country are joining us from different centers, including Peshawar, Islamabad, Lahore, Karachi, Multan, and even from across the sea.
Doesn't it actually? Sorry.
So over to Dr. Akifullah Khan for his presentation. Thank you, sir.
Thank you, Dr. Zareen and Professor Zareen and his able team for inviting me to this esteemed forum. It gave me an opportunity to introduce nuclear medicine in general to the fellows who are appearing in their fellowship exams and who are preparing for their fellowships. Because nuclear medicine is a smaller specialty which has got a little exposure into the general mainstream medicine. So primarily my talk would be aimed at the molecular imaging of the head and neck. Briefly, I'll be just highlighting few things about the nuclear medicine itself. It would be interesting for all those who have joined in the earlier part of the discussion. So I have been more than adequately introduced by Professor Zareen, and I am grateful for his kind and encouraging words. So we all live in the world of images. We collect images of our loved ones, of anything which is beautiful, anything which is containing some information. So the images have got a very special role in our day-to-day life, as we can see by nowadays various social media apps. They concentrate, they focus primarily on the images. So these images are carrying, in fact, information. Images are also very good for record keeping, because in a single page, you record a lot of information and that are revisited as memories. We use these images for communication as well. Because if you describe somebody, the appearance of someone in words, it becomes an essay of many pages while describing somebody. But if you show his image, so the data about that particular thing is transferred much quickly to the brain of the other person to whom you want to transfer that data. And the data in the image is short. It doesn't overburden you as compared to the data in the words. So the brevity is the hallmark of the imaging. Then images are reproducible. If you show somebody one picture and again you show him that picture again, so it's reproducible. You can use these images for the reproducibility of the data. And of course, we take images for pleasure, for joy. Like we have a lot of images related to our nature, our loved ones, and of course, of anything of interest to us. So we use these images for our day-to-day pleasures as well. So reading medical imaging is a science as well as an art. So I'll be describing how the nuclear medicine images are different from the images of the radiology, and how do we take these nuclear medicine images into our everyday uh, understanding of the human um, uh, disease process and as well as its physiology. This is an image of a very famous painter known as Pablo Picasso. And this is a very famous quote of him, that art is the lie that reveals the truth. And similarly, I say the scientific truth can be a lie if not properly interpreted. So the interpretation of the image is of utmost importance in understanding the disease. So my wife is an archaeologist, so I have some interest in the archaeological stuff. And these are some paintings that I took from the internet. These are paintings, some 35,000 years old paintings from the caves in Lascaux, France, and they describe. So these are some of the initial efforts of the human brain related to imaging. And let us take it a bit further. These are some of the images taken from the caves in Argentina. These are called the Cueva de las Manos, or the cave of the hands. And you can see a lot of hands printed on the rocks. And I take these hands as the first medical imaging. These are some 18,000 years old paintings or the images, and how they may have been produced. They have been produced by spraying some pigment onto the dorsum of the hand, and this shows our inquisitiveness about knowing ourselves. Later on, similarly, instead of the pigment, you must have heard that Röntgen sprayed some X-rays onto the hands of his wife and took the first radiograph, and the imaging, the story of the medical imaging started from there. But I take these initial efforts as to be as important about the human mind, to be very inquisitive about the human body. And these are the images of the Röntgen's wife with the wedding ring of the Röntgen's wife right there. And these are the nuclear medicine images of the hand. I will be telling you in coming few slides that how nuclear medicine images are different from those of the radiological imaging. Now, anybody who can remember this gentleman who's no more with us, and this is my old picture from 2006. There are mustaches, and I'm now a bit bulkier than I was. So if anybody who can remember this gentleman, he can text or he can message his answer into the discussion. Now, this is Stephen Hawking, if somebody has correctly identified this person. So from here, I take a turn into the images of the function. Why images of the function is more important? Because it is the function which is the true indicator of life rather than the structure. Appearances are often deceptive, as I said, that sometimes the scientific truth can be a lie. And so sometimes something appearing on a radiograph something appearing on a CT scan can be deceptive and it can be a lie. So how things function is more important than to a patient as well as to the physician than how they look. Like the appearance is lesser important as compared to the look of the as compared to the function of that particular organ. For example, a paralyzed hand is as good as a normal hand structurally, but it has got no function. So that's why the paralyzed hand has got no significance to the person who is holding, or who's having that arm or that hand. So the function is very important to the patient. Then the important thing is the biochemical changes or the functional changes, they occur much earlier than the structural changes. So if you can identify the biochemical or the functional changes, you can pick the disease at an early stage. So imaging of the function is important, and that is why in nuclear medicine, we image functions of an organ or an area, or uh, we discover an area of lesser functionality in comparison to the normal function. So this is the basic principle of nuclear medicine. We focus on the function of a particular organ or a part of that organ. If it is lesser functioning or hyper functioning, then we pick it up with our biochemical markers or radiochemical markers. And various functional parameters like blood flow to the receptor densities can be exploited using these functional imaging modalities. So what what physiology is to anatomy, similarly, the nuclear medicine is to radiology. So you would have heard a very famous misra of Mirza Ghalib, that धोखा देते हैं ये बाजीगर खुला. So we perceive people and we perceive things on the basis of the appearance most of the time. Like when we talk about something, he's a good person, he's a bad person, he's rich or he's poor, he's friendly or he is unfriendly. We all base these assumptions on the appearance. Although all these emotional and stable, loving, caring, and vice versa, pretty or ugly, these are all functional parameters, but we perceive them by looking at people, and that is why we get misled or misguided, and most of the time people get disappointed, like हमने क्या सोचा था और कैसे निकल आया वगैरह वगैरह. So from here things get interesting. So I take another step further. If in my audience anybody can tell whether this cat is awake or it's deeply thinking, it's about to sleep, or is this kitten is sleeping, or is this kitten dead? On just the picture, on the basis of this picture, we cannot make it out. But if you take the nuclear medicine perspective of this kitten to a nuclear medicine person, if we do a brain scan of this kitten, so the awake, the deeply thinking, the about to sleep, the sleeping, and the dead would have 3-4 different kind of images. So functioning is more important than the appearance. And if you do a CT or an MRI of this kitten, they will all look the same because they cannot differentiate on the basis of the structure what this kitten is going through. So I showed you the picture. Some of you might have thought that I'm standing beside the famous Stephen Hawking, but it was in fact a statue of the Stephen Hawking when I visited Madame Tussauds in 2006. So functionally, if it was a radiological imaging modality, the Stephen Hawking would be there. But if it was a functional imaging modality, the chair would have been empty. So because there's no life in Stephen Hawking, so in nuclear medicine, this Stephen Hawking would have not appeared on the picture. So going a bit further, this was just to uh, give you a brief philosophy of nuclear medicine to you guys. And now I'm coming to the definition of nuclear medicine, that it is that branch of medical science that deals with the applications of unsealed radioactive sources for the diagnosis and treatment of certain diseases. So it's not like uh, homeopathy or any other science which claims to be effective in every kind of diseases. So in certain diseases, we have got the capacity to treat and diagnose, and we use the unsealed radioactive sources for this purpose. So that is how we define nuclear medicine. So we have different kind of subspecialties in nuclear medicine. And the diagnostic nuclear medicine, we use some lab procedures which we use for hormone or tumor markers testing. And then in vivo testing, we image the body organs. In therapeutic nuclear medicine, we apply the unsealed radioactive sources for the treatment of certain diseases. So now coming to the main topic of today's discussion, that is the thyroid imaging. So thyroid is a very interesting organ. It has got two types of cells. I won't be going into the details of the anatomy and the physiology, but the important aspect of the thyroid is that it has got a specialized kind of cells which has got a function which is different from the rest of the body organs, and that is it concentrates iodine in a very high quantities against the concentration gradient, and the concentration of iodine is sometimes 100 times greater in the intracellular compartment of the thyroid gland as compared to the other cells of the body. There are certain other cells that also concentrate a bit of radioactive iodine, but they don't store it for a very long period of time. But they do take up, it includes the parathyroids, stomach mucosa, and salivary glands by and large. And the surplus iodine is excreted through the kidneys. So I'll be just going through how do we use the thyroid imaging in identifying different diseases. So thyroid scan is primarily a scintigraphic procedure. Like the patient is given intravenously a radio tracer which is identical to the iodine, and the thyroid would take up that radio tracer into the thyroid, and the emissions from the thyroid are detected on a gamma camera, and that gamma camera then detects the distribution of the pertechnetate in the thyroid gland. So we use usually the pertechnetate. The pertechnetate has got a molecule which is very much similar to the iodide. But once the thyroid takes up the pertechnetate, it does not organify it into a hormone. So the trapping, it deceives the trapping mechanism of the thyroid. So we use it to identify the hyperfunctioning thyroid. Whenever there is increased trapping of the pertechnetate, we take it as a hyperactivity of the thyroid. And we evaluate the function of the thyroid lesions. If you have some structural lesion found on clinical examination or on ultrasonography. So if you want to see if this nodule is hyperfunctioning or hyperfunctioning, so we use this pertechnetate for imaging of these nodules. And I'll be showing you few examples in this regard. So this is a normal thyroid scan. You see some uptake in the right lobe. This is the left lobe. This is the planar image. These are the submandibular glands, and these are the parotid glands. Some activity in the, because they all uh, take up or concentrate a bit of a radioactive iodine, and they then excrete it into the mouth. So you see some of the activity in the other organs as well. So this is a normal thyroid scan. A lot of people think that the role of the thyroid scan is almost obsolete because now we have a very good ultrasound available, and one can identify the things in a much easier way. So uh, I would give you a few examples why the thyroid scan should be utilized, not in every thyroid nodule, but in certain thyroid conditions where we are in doubt that this thyroid is hyperfunctioning or not. So this is a diffusely toxic hyperthyroid gland. And if you see, you don't see any background activity. All of the activity has been concentrated by both the lobes of the thyroid gland, and you don't see any submandibular or the parotid or the because whatever activity you have been giving to the patient has been taken up by the thyroid gland. Now, this is another area where you can see a cold nodule in the left lobe of the thyroid gland. And now this patient has got a nodule in the left side of the neck, and that corresponds to that hypofunctionality. And this is another one where we can see a cold area over here in this thyroid gland. But nowadays, we are not utilizing the thyroid scan in evaluation of the nodules, rather than we utilize it for the evaluation of the function of a nodule. So I'll be telling you why we are doing scans in certain selected patients. Now, this is a case where you want to give radioactive iodine to an elderly lady, and the patient has got a multinodular goiter. You want to know whether this patient would benefit from the radioactive iodine or not. So you give them the pertechnetate, and the pertechnetate is trapped into the thyroid cells, and later on you find an image where you can see a lot of hot nodules. So if you give radioactive iodine to this particular multinodular goiter, this is the patient who would benefit from the radioactive iodine therapy as a case of toxic multinodular goiter, as compared to those if the patient's thyroid is saturated with too much of a, sometimes the GPs give these patients Lugol's iodine, and the thyroid is super saturated, and it's not taking up any radioactive or any iodine whatsoever is given to this patient. So though the phenomena of hyperthyroidism would be there, but the radioactive iodine would not be entering. So we do a multinodular goiter scanning when we are planning to give radioactive iodine in these patients. Now, this is a case where we got a nodule in the lower part of the left lobe, and this is a toxic multinodular or hyperactive solitary toxic nodule in the left lobe of the lower pole of the thyroid gland. This is the left lobe, this is the right lobe, this is some activity in the hypopharynx, and this is the toxic nodule in the left lobe. So this is a candidate, a very good candidate for the radioactive iodine, because it has got a functioning nodule. Excuse me. So we have a lot of patients coming into our nuclear medicine departments where they are labeled as hyperthyroid, and the physicians want them to be treated with radioactive iodine. but sometimes there is a misjudgment of the fact that the thyroid is not hyperactive, rather than it's inflamed, and all of the uh, preformed T4 or T3 is released into the circulation, which shows a hyperthyroxinemic state. But at the same time, the patient's thyroid is totally uh, incapable of concentrating iodine. These are the patients who will not benefit from the anti-thyroid medication as such. So I would suggest that if you come across a hyperthyroxinemia, it does not mean hyperthyroidism. So hyperthyroidism can only be established by seeing increased uptake in the thyroid gland, or if the thyroid gland is not visualized, you have to look for other places, because it's not essential that the thyroid would be located in the neck. Sometimes it can be in the mediastinum. Sometimes there are areas which are not even in the upper body. It can be found in the ovaries, like you would have commonly come across thyroid functioning tissue in a struma ovariae, which is a teratoma-like condition. So these are areas where you would be seeing radioactive iodine concentration right there to the ovarian mass, rather than the thyroid by itself, because the thyroid would be suppressed in those cases. This is another case of thyroiditis. Um, and these are some more large diffuse toxic goiters. This is another large diffuse. You can see a small pyramidal lobe. This is another hot nodule. These are multiple cold nodules. This is another cold nodule right there. There is another very interesting condition when you see some swelling on the dorsum of the tongue, and you're not sure what it is. And if you do a pertechnetate simple scan, you can find out that this is the functioning thyroid tissue on the dorsum of the tongue, rather than some tumor or some other mass condition of the dorsum of the tongue. And this is another dorsum of the tongue mass. Now, I'm coming to another brief topic, why we do image and how we do imaging in differentiated thyroid cancer. So as I told you that radioactive iodine, also known as radioiodine, um, we use the iodine isotope 131 for the treatment, and its iodine is naturally occurring, and it's a metallic element, and is essential for our diet, and our body requires a small amount of iodine to produce thyroid hormones essential for the growth and development. So the cancers of the thyroid, they retain their, sometimes they retain their capacity to concentrate radioiodine. And this capacity of a cancer, of a thyroid cancer, to concentrate radioiodine can be utilized for the diagnosis and staging of the thyroid disease or thyroid cancer. And ultimately, radioactive iodine is very much used in the treatment of differentiated thyroid cancers for more than 60 years. And we can detect where the cancer is, or it has came back or recurred when there is elevated levels of tumor marker, that is thyroglobulin, in the thyroid cancer. When we see that, so we can utilize that for, I don't know from where did I get these red marks, but just forgive me for these red marks. Okay, so what is radioactive iodine whole body scan, and how we do a radioactive iodine whole body scan? So the radioactive iodine whole body scan involves the use of small amount of radioactive iodine and that is given to the patient orally, and the patient is asked to come after 24 or 48 or sometimes 72 hours, and the patient is imaged under the gamma camera from head to up till the knee regions, and we look for any focal area of reduced or increased radiotracer uptake or an abnormal radiotracer uptake, what you can call, and that area is identified and localized. So thyroid cancer cells, as you know, absorb iodine more as compared to the surrounding tissue. So that is why we use this radioactive iodine for tracing or for following the radioactive the thyroid cancer. Some of you might say that we have heard that the thyroid cancer appears cold on the thyroid scan. Then why does a radioactive iodine 131 scan, the thyroid cancer comes to be hot? So the reason is like the cancer is of course having lesser capacity as compared to the normal thyroid gland. So relatively it appears cold when you are imaging it inside the normal thyroid gland. But once the normal thyroid gland is removed, so the thyroid cancer itself retains the capacity of concentrating iodine. And over the time, yes, the thyroid cancer may reduce its capacity to concentrate radioactive iodine, but most of the time in the earlier part of the disease, the thyroid cancers are very much iodine avid. So the radioactive iodine scans are also done in the care and the management of patients with differentiated thyroid cancers. So most of the cancers of the thyroid, as you know, are differentiated thyroid cancers like papillary, follicular, and Hurtl cells cancers. So these cancers can be very adequately imaged and treated using radioactive iodine. So to many of you, these spots may not make much of a sense, but you should take it like from here, the head starts, and these are the shoulders, and this is the whole body of the patient. And here you can see a focal area of increased radiotracer uptake, and then a small area of increased tracer uptake over here. And you can see a focal area over here. This is the anterior image, and this is the posterior image. So you can see this area is appearing here, and these. So this shows a focal area of a tumor, and these are some lymph nodes which are concentrating the radioactive iodine, so they can be treated later on with radioactive iodine. Now here you can see this is another whole body scan. Here this is the head region, this is the neck region, and you can see the smaller lung. These are the uptake in the lung. So this patient has got extensive lung metastasis. This is another case of carcinoma thyroid having metastasis in the lungs and some mediastinal lymph nodes as well. Now, this is a metastatic follicular carcinoma, and the patient has got a focus of uptake in the left humerus, which is also seen over here, and some other foci are also seen in the pelvis. And if you note that thyroid gland is not visible in the neck that prominently, but because this was ablated or removed surgically, but the disease has already metastasized to the humeral shaft. Now, to many of you, these are just spots, but to a nucleophysician, they mean a lot of a lot of interesting information. These are just the nuclear medicine imaging. Later on, some structural imaging modalities were added to the nuclear medicine imaging modalities to increase the localization of these tumors. And I'll be talking briefly about them in the coming few slides. Now, this is a very adequately treated a patient with radioactive iodine. and you see no activity in the neck, nothing in the lungs, a bit of activity in the stomach because it's excreted in the stomach. The excess iodine is being excreted in the urinary bladder. So this is an adequately treated on a routine follow-up patient. Now, this I was telling you about the PET CT, where we can use the hybrid imaging techniques, and you can see this is a CT scan, and you can see a lymph node right next to the trachea, and these are the superimposed images. The nuclear medicine images and the CT images are superimposed. Now we are having an equipment. In IRNM, which we call a SPECT CT. It's not a PET CT, but SPECT CT, in which we image the patient with a nuclear medicine technique, and concomitantly we also image the patient with a SPECT with a CT, and then we fuse both the images. I'll be showing you a few of my cases which have been done with the nuclear medicine technique, as well as with a hybrid CT or concomitant CT. But this is a PET radio tracer image, and here you can see the FDG PET localizing in the thyroid. Now, when we do the PET imaging and when we do the video iodine, once the patient's thyroid becomes more and more de-differentiated. Like the differentiated one would be concentrating the iodine. Uh, as long as the patient's cancer is differentiated, it will keep on concentrating the radioactive iodine, so it will be easily imaged using radioactive iodine. But as the patient's tumor becomes de-differentiated or undifferentiated, so it will stop concentrating the desired amount of iodine, so it will not be able to be visualized on the nuclear medicine scan. So then we have to go to other imaging modalities. Then as you know, the more undifferentiated tumor is concentrating, is having a higher metabolic rate, so it start concentrating the more of glucose. So we image them later on with the FDG PET CT scanning in the later part, or in the undifferentiated cases. Now, how would we know that this patient has got an undifferentiated thyroid cancer? Because the tumor marker would be rising, and we won't be having any evidence of the disease on the iodine 131 whole body scan. Now, coming briefly to the parathyroid images, I'll be showing you few parathyroid images. Now, how we do a parathyroid imaging, slightly a bit of an introduction of that as well. The parathyroid images are being acquired because they don't concentrate iodine. But as you know, the parathyroids are not visible on the thyroid scan. And they are very difficult to localize on the other imaging modalities, like if they are small on the CT, or if they are ectopic on the CT and ultrasound, they are difficult to localize. So we do technetium labeled methoxy isobutyl isonitrile. In short, we call it MEBI. A MEBI scan, usually the MEBI scan is done for the myocardial perfusion imaging, but we use this technetium MEBI, or Acesta MEBI, some people call it Acesta MEBI scan, for the parathyroid. So this parathyroid adenoma cells, they are very compact, and they have a very high content of mitochondria. And these technetium MEBI parathyroid scans are based on the principle that this MEBI concentrate into the hypermetabolic areas. So the parathyroid adenoma is a compact mass of cells, which and the cells which are very rich in mitochondria. So these Acesta MEBI would concentrate into these adenomas, and then we do two images, because this maybe is also taken up by the thyroid, but the thyroid washes out with the maybe in the initial part, and then we do a delayed scan. So we call it a two-phase maybe parathyroid scan. In the initial part, we see parathyroid adenoma and the thyroid. Then the thyroid is preferentially washed out, and then the adenoma strikes onto the eyes. So that would be interesting to see if you look at these scans. Now, this is a parathyroid adenoma, not well localized over here, but on the delayed images, you can see a very good parathyroid adenoma localization. So we usually guide the surgeon by marking them on the skin that this is this much deep and this much in this area, you can find exactly the parathyroid adenoma. And you see a lot of good uptake uh, in the heart. So we use this maybe for the myocardial perfusion imaging. So you are seeing the heart as well. And this is another huge parathyroid adenoma. This was a recurrent adenoma. So you can see this as well. This is another parathyroid adenoma. You see, it's not in the neck. There is a multinodular goiter, and you are seeing the adenoma in the mediastinum. Now, this is a SPECT CT scan done at IRNM, and you are seeing a CT scan, and at the same time, a maybe two-phase scan, and you can see a focal area of increased radiotracer uptake just behind the left clavicle, and this is a parathyroid adenoma. This is another parathyroid adenoma right there. No, this is a marker. You can see it's here. This is another one. Can you see it's right there above the right atrium, a parathyroid adenoma. So parathyroid, it can be very adequately imaged using the isotopic techniques. So let me summarize the whole neck imaging using the nuclear medicine technique. That we do a thyroid scan for the imaging of the thyroid gland itself. Then we do related to the thyroid cancer that primarily involves the radioactive iodine. Then I talked briefly about the parathyroid adenoma, where we localize it with the technetium sestami B two-phase scan. There were certain other smaller things like octreotide scans. You would have heard about the octreotide scans. We use these octreotide scans, which are the somatostatin receptor analogs. We label them with technetium, or we label them with a gallium 67, and we use them for the imaging of the medullary carcinoma thyroid. So I would conclude my talk over here, because I'm expecting some discussion from my colleagues. So thank you all of you for your patient listening. I hope I didn't rush through the whole subject very quickly, but I don't go for a lot of say pauses in my presentation. So I hope you enjoyed the discussion. Thank you.
Thank you, Dr. Akif. Dr. Akifullah, who has started his discussion from a very interesting starter, followed by a very delicious main course. Here, I will be justified to say that some people have got God-gifted qualities to present their viewpoint in front of people, and that's what Dr. Akifullah has done so very nicely, precisely. And I'm hopeful that participants might have got a lot of from this discussion, and they would have a lot of questions, of course. If you don't get anything from the discussion, you don't have any question. If you do receive a lot of knowledge, so you have more questions in your minds. So the forum is open for discussion, and the participants are most welcome to ask questions. Obviously, from a single person at this session, and he is Dr. Akif. And rest, we all are ignorant about this nuclear medicine and its related services. So, Maria?
Yes, sir.
Assalamu alaikum.
There were a few questions in the chat.
Maria, first take questions by hand raising and then ultimately from chat box.
Okay. So participants, you can raise your hands and then you can unmute yourself. Okay, Dr. Israr.
Whoever is asking question, please share your video also.
Dr. Israr, here I want to ask a question. After total thyroidectomy, when we go for the thyroid scan, and what is the prerequisites to do thyroid scan?
Yeah. Can you hear me?
Yes, sir.
Okay. We don't do really a thyroid scan after the total or subtotal thyroidectomy. We prefer to go for a radioactive iodine whole body scan to look for the remnant that has been left behind by the surgeon. If the patient is high risk, like if the patient has got all the risk stratification parameters, which includes age, gender, the histopathology, the size of the tumor, all these risk stratification, if the patient is based on the high risk group side, then we would go for a radioactive iodine ablation. Then this whole body scan will indicate how much remnant is there, and are there any metastatic deposits which have not been addressed at the time of the surgery. Because most of the time in our clinical settings, the tumors are removed inadvertently as a part of the surgery for the multinodular goiter. And the workup is not that complete in the initial part. So then we come up with metastatic disease in the bones, and then with metastatic disease in the lungs. So to address that, we do a whole body scan. An alternative is that if we have to go for a radioactive iodine, then we give a higher dose of radioactive iodine, and we do a post-therapy scan. That is a more reliable scan as compared to a diagnostic whole body scan. Because if there is some huge remnant has been left by the surgeon, whole of the iodine would go, and it will be taken up by the neck remnant, and little will be left to be taken up by the lung mets, for example, if they are there, or will be taken up by the bone mets. So most of the iodine will be snatched by the remnant which is there in the neck. So what we do, we give a huge dose of radioactive iodine to ablate the thyroid, because that is such a dose. Like if we give in the diagnostic setting, we give a 3 millicurie dose, but in the therapeutic setting, we go above 100 millicurie dose. So that is a 30 to 40 times higher dose that we give to the patient. So the chance of getting a metastatic deposit to be detected on the post-therapy scan is much higher than as compared to the diagnostic whole body scan. So we do not do a thyroid scan post-surgery, but I have personally, I do it in one condition. If I'm not sure that the surgery is how much adequate, so I can go for a simple thyroid scan to look for the remnant size. So I estimate the remnant size on the base of a pertechnetate thyroid scan, which you people understand as a thyroid scan. So if the remnant is too small, like less than a centimeter volume, then I would go for a outdoor basis ablation. Like I would go for a smaller dose, like 29.9 millicurie of a radioactive iodine that I give it on the outdoor basis. So the patient is not going to be admitted to my hospital. So the patient will receive the radioactive iodine therapy at an earlier stage. I hope I answered your question. I'm not confusing you too much, but thyroid scan is not done regularly after the thyroid surgery. We do a diagnostic sometime whole body scan, but mostly nowadays in most of the institutions, if iodine therapy is being given, and it has to be given, then you give a therapeutic dose, and that is followed 10 days after the dose with a whole body scan. I hope I answered your question.
Thank you so much.
Because it's a forum of surgeons, so I try to be generalistic rather than very nuclear medicine oriented.
Anybody else?
Dr. Bushra?
Yeah, Dr. Bushra from JPMC.
Assalamu alaikum, sir. Sir, I'm Dr. Haris Aptabad. Sir, I want to ask a question about in which condition do we give IV iodine tracer, and in which condition do we give to tell the patient to swallow it? What is the difference between these two, via swallowing or in the IV tracer?
So your question is when we give the oral dose of radioactive iodine and when we give the intravenous dose of radioactive iodine?
Yes, sir. Yes, sir.
Okay, we do not give radioactive iodine intravenously in our country or in the rest of the world nowadays. All of the radioactive iodine is given orally. Only the pertechnetate, which is not actually the iodine, but an analog of iodine. It resembles the iodine in its shape, and it is taken up by the thyroid as an iodine. It is trapped by the thyroid cells, and it is not what you can call organified. So let me give you another interesting insight into the subject. Have you heard about the organification defects? If there is an organification defect, we can detect it using radioactive techniques. We give radioactive iodine. The iodine is trapped but not organified. We give a perchlorate. So all that is not organified is released back into the circulation. So we can detect by using an iodine scan the organification defects as well. Having said that, iodine is mostly given in the form of oral liquid in Pakistan. In some countries, it's given in the capsule form for good radiation protection purposes. But now we use it. In Pakistan, we give it in a fluid form, in drops. People call it.
Okay, sir. Thank you, sir.
Sir, what people call it, sir?
Katre Saski.
Okay. So participants, please, we have got enough time. I think Dr. Akif is not in hurry. So you take maximum benefit of this occasion. I don't think we will be able to catch him again in the near future.
Assalamu alaikum. My name is Dr. Sadaf Rahman, and currently I'm preparing for Part 2 exam. I had two questions. If you could please. Number one is, what are the contraindications to radioactive iodine scanning? And secondly, what are the precautions post-procedure that you give to the patients after the procedure? Thank you.
Yeah, there are certain absolute contraindications to the diagnostic or the therapeutic radioactive iodine doses. One of them is the pregnancy. The other one is the lactation. Both has to be excluded before giving even a smaller doses of radioactive iodine. Why we do not give in lactation? Because the iodine is secreted into the breast milk. Not only it will be given, it will give excessive radiation in the milk to the baby or to the infant which is being fed by the mother, but also it will increase the radiation burden to the very much radiation sensitive organ, which is the breast. So we try not to give radioactive iodine in cases where the lady is lactating. Even if she stops feeding her child, we advise to at least wait for few weeks before we give radioactive iodine. I personally prefer to give certain medication to cease the lactation. And that also help to reduce the vascularity and the iodine flow to the breast. And the other is the pregnancy. All those patients who has to undergo radioactive iodine therapy or for CA thyroid or for hyperthyroidism should have a pregnancy test done if the lady is in the reproductive age group and the suspicion of the pregnancy is there. Rest, there is no contraindication as such, except for iodine allergy, which is very much rare. And in iodine, in radioactive iodine, we give very small amount of iodine. It's quantitatively very small, quantitatively, like radioactively, it contains a lot of radiation, but as per amount of mass, it's in micrograms.
Thank you very much, sir. And another thing was, what exactly precautions do you give post-procedure? Thank you.
For this, I've recently recorded a video on the what precautions should be taken. Like if we give predictive iodine in a higher doses, like from 10 to 15 millicurie, which we usually give in hyperthyroidism, the outdoor. So I can share that video with you. It's a 4 minutes educational video for the patients. We provide them to the patient, and it includes, as we all nowadays, you all know about the distancing, about the time. We nuclear medicine people are practicing these COVID principles from the very beginning, because the radiation protection involves 3 basic principles, and that is called the time, distance, and shielding. So we try to stay away from the radiation, stay for a lesser period of time with the radiation, and to put a barrier in between the radiation and yourself. The same is you practice with the COVID protections. So that is we instruct the patient to keep away from the pregnant woman, children, to stay in a separate room, to use the separate toilet. When you use the toilet, you can flush it twice. If you don't have a proper flushing, you can put extra amount of water in the flush to take that radioactive urine away from the premises of the toilet. Then the patient is asked to wash the hands frequently. The patient is asked to drink ample amount of water, to void frequently, because the surplus iodine is concentrated into the urinary bladder. Some misconceptions are there among even the medical professionals. They tell every second person that you will become infertile while using radioactive iodine. It never happens. It's scientifically imprudent. A patient with such a smaller dose to the ovaries, which is even lesser as compared to a patient undergoing a IVU X-ray, which you frequently prescribe. And these contrast-related urographic tests are giving more radiation to the ovaries as compared to the radioactive iodine which we give to the patient. But most of the time, when the patient comes from other departments, they are being told, okay, you are panzoso kalonasiate family, your family is complete and you are above a certain age, so you can safely undergo a radioactive iodine, because after this you won't be able to conceive. So these patients, we also advise them that you take proper contraceptive measures for at least 6 months, because the patient may be retreated. Sorry. So the patient may need a retreatment after the first treatment. So the patient is advised not to get pregnant, because it will jeopardize our further treatment options. So we ask the patient not to conceive. This is also a part of the precautions that we tell our patients. Some patients are so afraid of these radiation that they burn their uh, clothings or their blankets or their beddings. So it's not like this with radiation, with burning radiation cannot be destroyed. What we should ask them to gather all your clothings and to put it in a plastic bag and just to put it in some basket and reuse it after 2 to 3 weeks when the radiation has decayed by itself. So these are the precautions we tell our patients to take.
Thank you so much, sir.
Dr. Maria, Dr. Maria,
Yes, sir.
after the session as well, make sure that the video which Dr. Akif is talking about is uploaded on the WhatsApp group.
Okay,
Assalamu alaikum, sir.
Wa alaikum salam.
Sir, I am Dr. Hafiz Umar Farooq from Bahawalpur, GVH.
It's nice
sir,
to
I have a
have you,
question.
Umar Farooq.
Yes, sir. Thank you, sir. Sir, suppose we receive a patient with toxic multinodular goiter. Then in that case, what is the significance of thyroid scan, especially if we have to go for a total thyroidectomy after all, in any case, after getting the patient euthyroid?
Yeah, if you are not going for a radioactive iodine therapy, then there is no role of doing a thyroid scan before. If you are planning and you have made the patient euthyroid, so there is no role of doing in a multinodular goiter. There is no role of doing a thyroid scan. I would advise you make the patient euthyroid, go for the surgery, and if the histopathology is suggestive of some malignancy, because multinodular goiters are mostly by the general surgeons, they are taken as benign. But that dogma has also been now destroyed. Now people say that there are equal chances of having an occult malignancy inside a multinodular goiter. So never ask your patient to take the histopathology that easily.
Yes,
हमें पता है it's a benign thing and you can go away with it. So always advise your patient to do a detailed histopathology in all the cases. If the patient turns out to be malignant, then there is another story which starts like resurgery, what we call a completion thyroidectomy, followed by radioactive iodine therapy and scanning as per protocols.
Yes, sir, because the indication of thyroid scan is toxicity and nodularity. So patient with toxic multinodular goiter in Viva exams, when our examiner asks, what is your investigation plan? So we tell him that we will go for thyroid scan. He asks, what is the significance if you have to go for thyroid?
Yeah, if you are asked that what is the significance, there are certain gray areas and opinions may differ. But nowadays, under the new guidelines, thyroid scan is not recommended if the patient is planned for surgery. But if the patient is being planned for radioiodine therapy, if you are getting a hyperthyroid patient and the patient is being planned for radioiodine therapy, I would definitely love to have a thyroid scan done to be sure that the iodine that I'm giving, which is a precious thing to me, is concentrating in the thyroid gland rather than excreting, not touching the thyroid, because the thyroid is super saturated, number one. The multinodular goiter has got some thyroiditis-like element, and the hyperthyroxinemia is primarily due to the release of the preformed thyroxine or due to the trauma or whatsoever reason. The thyroid is not concentrating appropriate amount of iodine. So I would definitely go for a thyroid scan before going for a radioactive iodine therapy. But as far as if your plan is to go for surgery, then obviously you might not opt for a thyroid scan. Make the patient euthyroid, and you can go for surgery.
Thank you, sir. Thank you very much.
Thank you, Omar.
Sir, I have one question. Sir, if we are giving radioiodine therapy for the management of differentiated thyroid cancer, Sir, for how long or how many sessions or cycles will be required?
We usually give radioactive iodine therapy once, and we hope that this single dose would suffice for this particular patient. But theoretically, this is our dream, or this is our hope, and this is what we expect. But usually it doesn't happen like this, and the thyroid gland is in some percentage and significant proportion of the patient is not ablated with the first dose. So there are different conditions. Like first you have to understand whether it's just a remnant of the thyroid gland lying in the neck, or the patient has got a metastatic disease at the time of the. So if the patient has got a metastatic disease, then there is a large volume of disease there. So in the initial first dose, the thyroid remnant is ablated, and in the later doses, we try to eliminate the lungs and the bone metastasis, or to address them. But in very small remnant, most of the time in a single dose of radioactive iodine therapy in 30 to 40% probably, if I'm not wrong, is sufficient to ablate the thyroid gland. With the smaller doses and with the higher doses, it's around 80 to 90% of the cases, they get their remnant ablated with a higher doses, like 100 millicurie.
Okay, so thank you, sir.
You're welcome.
Dr. Bushra is next. Yes, Dr. Bushra. We cannot hear you. Okay, anyone else?
Dr. Bushra, you should unmute yourself and then speak to.
By Dr. Zakir, that what is the difference between a parathyroid adenoma and Hertel cell on system EB scan, because they share the same mechanism, he says.
Yeah, when we are coming across Hertel, like one thing should be clarified, like this Hertel change or Hertelization is a pathological process. There is excessive eosinophilia in the cells. So this is called the Hertel change. So in the Hertel cell carcinomas, these Hertel changes are there in the carcinoma itself. Like there are a lot of eosinophilic granules in the cytoplasm. So one thing should be made clear, that Hertel by itself does not signify a particular tumor, but this tumor contains a Hertelization, like it contains the eosinophilic granules inside it. Now, every carcinoma share the same mechanism as the system EB scan is used for imaging of the parathyroid. So the system EB scan utilizes the mitochondrial uptake, and similarly all the tumors they also have excessive mitochondrial content and excessive metabolism. So the tumors are also being picked up by using the system EB. Sometimes when we don't have any access to the PET CT scan, as most of our centers don't have in our country. So what we do, if the patient's thyroglobulin is very high and the iodine scan is coming negative, then what we do a system EB scan and see a thyroid patient. And sometimes we pick a thyroid recurrence in the neck or in the mediastinum by using a system EB scan. So Dr. Zakir is very much right. Like both these things, both these tumors and the parathyroid adenoma uses the same mechanism of action, but the mindset of the referring clinician would determine what you want to do with that. Like if the system EB scan, we are also using it for the heart imaging. So if somebody sends me a patient with a MEB scan for the myocardial perfusion, I would be concentrating more on the myocardial perfusion. Like if somebody sends me a patient with a rising TG and indeterminate whole body scan or the no iodine no iodine uptake on the whole body scan and a rising TG, then if I am doing a MEB scan, I am having this thing in my mind that I'm looking for a neck nodule or a mediastinal nodule or a lung nodules on this scan. So I'm looking for that. So the eyes do not see what the mind does not know. So the eyes would be looking for that particular thing, what you are up to. So in the parathyroid adenoma, the setting is very clear. There is hypercalcemia, there is hyperparathyroxanemia, and we are focused on localizing a parathyroid adenoma with using adjunct other imaging modalities like a CT scan and ultrasound along with that.
Right, sir. Thank you.
Dr.
There
Mario,
is a question by Dr. Yes, sir.
you can read the question asked by Dr. Bushra from JPMC.
Sir, okay, sir. And Dr. Bushra is asking, why don't we do a scan in all the MNG patients? Why only in toxicity?
Yeah, it's very simple. Like you don't, in an MNG, you are going for surgery. If the patient is not toxic, you are going for surgery. If a patient is euthyroid, you do a thyroid ultrasound, you ascertain the extent of the disease sometimes, if it's a retrosternally extending or not, using a CT. And then after ascertaining all the extent of the multinodular goiter, you go for surgery. In toxic multinodular goiter, we do a scan because you have to look for the hyperfunctioning nodules, which nodules are the real causative nodules of hyperthyroxanemia. So that need to be addressed necessarily, that need to be addressed. Although in a multinodular goiter removal, you remove all the nodules, you try to remove all the nodules, but we would like to know which area of the thyroid is more producing more of the thyroxine. And here I must add to my surgeon colleagues, like if you come across a toxic multinodular goiter, and there is a huge toxic nodule which you have tamed down with the numericazole initially, and now the patient is under the operation table, and please don't squeeze during surgery that particular nodule, that particular area or press which contains the toxic nodule, because you may inadvertently by pressing the nodules which is toxic, you may release an excessive amount of thyroxine during surgery. So I would request all my surgeon colleagues that if you come across a toxic nodular goiter, so please during surgery, try to be very gentle with a goiter. Don't be too aggressive with pressing and pushing off during surgery, because the patient might go into a thyroid related storm and would create some problems for the anesthetist.
That is, thank you.
Excellent advice by Dr. Akif, that you, while dealing with endocrine surgeries, you have to be very much polite and
gentle.
Gentle. And same can happen to suprarenal glands also.
Yes.
We are very much careful in suprarenal glands, but we are less careful in thyroid surgery. And thyroid storm is one of the life-threatening condition.
Yeah, there are certain questions that let me go through the scroll. If something interesting comes into my
I wanted actually, let me ask.
There is one question somebody has asked. Hold on, somebody has asked about the iodine 123 scan. Yes, yeah, this is interesting. So iodine 123 is a gamma photon emitter which has got a smaller energy, and it is used for imaging only, but it is a cyclotron produced, and it is very expensive and not available in Pakistan. So it's ideal to have an iodine 123 scan before the therapy. But in Pakistan, we don't have it. So we have to rely on iodine 131, which has got a beta dose as well. Let me go through some more.
You are saying
somebody has asked about the.
So for whole body scanning pre-radioiodine ablation, We are using 131 scan here.
Yeah, we are using 131 because it's available with us. We don't have iodine 123.
Right, sir.
It is the disadvantage of iodine 131 is that iodine 131 is a beta emitter, so that we don't need for a diagnostic purpose. But the iodine 123 is a pure gamma emitter with a small energy gamma photon. So it is very lesser dose is being delivered to the patient, the diagnostic radiation dose. But while the iodine 131 is a bit, but most of the time we use the radioactive iodine 131 in those patients who are CA thyroid patients. So we are not afraid of these 3 millicurie because later on we have to give these patients higher doses like 100 to 200 to 250 millicurie. So we are not concerned with the 3 millicurie dose in those patients.
Yes,
It's
sir.
a bit of a selling gimmick as well because iodine 123 has to be marketed some way or the other. So to us, it doesn't make that kind of a difference. I may be challenged by other people, but it's a discussion with the colleagues. So I would say iodine 123 is a better option if you have it.
And another question was, why don't we use technetium 99 scan after total thyroidectomy? Instead, we use iodine scan.
I told you, like, we do iodine 131 whole body scan post therapy. Technetium scan is being done by few clinicians. I do it personally per technetate scan just to ascertain the remnant size when the patient is low risk and I have to just ablate the remnant. So I calculate the volume of the remnant. If the remnant is too big, I go for a higher dose. If the remnant is smaller, then I go for an outdoor small dose. So that is why we do a technetium scan sometimes. But most of the people, they don't prefer a technetium scan. They would go for iodine 123 scan or iodine 131 scan.
Thank you, sir. There is another question in the chat. I think this would be the last. The difference of effects of radioiodine on primary thyroid disease, ectopic disease. So what's the effect on ectopic disease?
If you give radioactive iodine in ectopic disease, like struma ovari, you want to say?
Yes, sir, maybe, or
lingual thyroid.
Lingual thyroid or some other.
Now, if if it's a multinodular goiter with retrosternal extension, the patient is old age, I would prefer a radioactive iodine therapy with a steroidal cover. That would be a better option. In lingual setting, in ectopic or undescended thyroid setting, surgery would be much better choice because if it's lingual, it is causing obstruction to the oral intake. So surgery would be a much advisable option. Probably some surgeon might think of re-implanting that particular tissue. But most of the time, these patients are already hypothyroid because the hypoplastic undescended thyroid tissue patients are usually hypothyroid. In my practice, I see quite a lot of hypothyroid patients when they have a lingual thyroid. So when you start them with thyroxine, their lingual thyroid do gets smaller and it regresses. In struma ovari, the treatment of choice is surgery. But if surgery cannot be performed for one reason or the other, like surgery can be contraindicated due to cardiac or due to some renal or some other comorbidities, then radioactive iodine can be given in such cases.
So it's another question to Dr. Syed Kazan. He's asking about digital subtraction scan.
Yeah, digital subtraction scan used to be done when we use dual isotope scans. dual isotope scans, they were being done in early 90s, when the first SESTA-MEB scan was performed by us at IRNAM in Pakistan, because at that time I was doing my MS project using the SESTA-MEB for breast imaging tumor in the breast. At that time, this SESTA-MEB was not yet registered. So I read a paper somewhere and I applied it in a two-phase MEB parathyroid setting. So we never did a two isotope study. In the two isotope study, they use thallium and pertechnetate. So that is an obsolete technique now. We have a MEB parathyroid two-phase imaging with a with a CT facility available, so you can better localize it with this technique. That is being done with thallium and pertechnetate. In one window you subtract the pertechnetate counts energy that is subtracted. That is a kind of an algorithm which is built into the gamma camera, and that subtract a particular energy of the 140 keV energy subtracted, and the smaller energy of thallium it stays there, so you can easily visualize the parathyroid adenoma. I hope I answered your question.
Right, sir. Thank you so much.
There is one question from someone related to orbitopathies. Graves orbitopathies. Radioactive iodine sometimes aggravates the Graves orbitopathies, but there are different views about the Graves orbitopathies. In some of the cases, the Graves orbitopathies, they are very much preceding the hyperthyroidism. In 30% of the cases, the orbitopathies would precede the hyperthyroidism. Like the eye signs would appear first, then the hyperthyroidism signs would appear. In the another 30% to 40%, both simultaneously appears. Like the eye signs and the hyperthyroidism, they present in one clinical frame, in one clinical setting. While in another 20 to 30% cases, the hyperthyroidism present first and the eye signs would present later on. So some people say that giving radioactive iodine in 20% or 15% of the cases may aggravate the orbitopathies. But there is another school of thought. Like they say, like I also follow that, like they also say that these are not those patients, these are those patients who are to be developing the orbitopathies later on. So the iodine by itself is not causing the orbitopathies, rather than this is the natural course of the disease which is causing the orbitopathies. So the Graves ophthalmopathies or the orbitopathies should be first calmed down with steroids, and if the activity score is low, then radioactive iodine should be given. So in ophthalmopathies, in the active ophthalmopathies, the ophthalmopathies has got different stages. The ophthalmologist would be in a better position to guide you about that. But if your patient has got red eyes and very progressive ophthalmopathies, it's better to refrain from radioactive iodine rather than control the patient with antithyroids, give steroids, and then later on, when the eye signs subside, because it will take the orbitopathies, it's said that its natural course is from 6 months, 3 months to 2 years it may take, and they ultimately burn out and a stable status is achieved. Nowadays, we don't see that severe orbitopathies which are causing any risk to the optic nerve damage or the visual acuity. So I hope I answered that question as well.
One question from Babar Hamid is asking about what is discordant scan.
Discordant scan, I think my colleagues are going through a a good read during my presentation. A discordant scan is the scan which is colder on the paratechnetate scan, but later on it becomes hot on the iodine scan, because paratechnetate is only being trapped while iodine is trapped as well as organified. So the iodine, when is taken up by the cancer cells, is incorporated into the tumor. So they will appear as compared to the cold, they will become slightly hotter. So the discordance is like it would be cold on the paratechnetate scan, it will be hot on the iodine scan. So it's a discordance.
Maria, any question yet to be answered?
Your session is quite interesting. I'm getting quite a hell of a...
Dr. Harris is asking about the therapy.
We are enjoying this session, sir.
I'm also enjoying it.
So Dr. Harris asked about iodine dose, 131, the exact dosing.
Regarding which pathology?
So he didn't mention.
Okay. For benign pathologies like hyperthyroidism, diffuse toxic goiters, we give from 10 to 15 millicurie. I go for a higher dose in the first instance because I want a higher cure rate. Some people go based on the size of and the uptake values, but preferably I go for a 15 millicurie dose. Then my multinodular goiters, in the multinodular goiters, we may go up to 30 millicurie. These are the average doses. Sometimes you may not get the desired result with even a 30 millicurie. Then later on, we may admit the patient for a heavier doses. Then for CA thyroid, we may go from 30 millicurie ablation dose to 100 millicurie ablation dose to even 250 millicurie to 300 millicurie dose for metastatic CA thyroid. In Pakistan, nobody goes beyond 250. I've given up till now one patient a 300 millicurie dose after doing a dosimetry. Very few people do dosimetries in radioactive iodine therapy. I do dosimetries in radioactive iodine therapy. We started this protocol when I was director at the Swat Institute of Nuclear Medicine, Oncology and Radiotherapy, CNOR. So we have quite few publications on that as well. So I hope if you do a proper dosimetry, you can go for a dose escalation. In the dosimetry, you keep an eye on the dose to the bone marrow. So your bone marrow dose should not exceed a particular limit, and your dose to the bladder wall and the kidneys should not exceed to a particular limit. So if you keep that limit lower, so you can go for a higher doses.
So is there any difference for dosage for bony metastasis and other metastases?
Yeah, the bony metastases are considered to be very notorious to respond because there is some people say that the calcified bones are giving some attenuation to the beta particles as well. The lung mets are very much amenable to smaller doses of treatment, and they get better during the treatment, because even with lung mets, even with the radiological abnormalities on the lung mets, the survival of 6 to 10 years is not that difficult. But with the bone mets, we tend to give higher doses, like 250 millicurie doses. But for the lung metastasis, we don't exceed a certain limit that we call 80 millicurie of the whole lung volume. The dose to the lungs should not exceed at 80 millicurie. It does not mean 80 millicurie dose should be given to the patient. Rather than 80 millicurie retained at 24 hours should be the limit, because it can create a condition what we call radiation pulmonitis, and later on leading to fibrosis. So lung fibrosis can be avoided because these are very small microscopic metastases that distributed, as I showed you, the scans in my previous presentations, that they are very much homogeneously distributed through the lungs. So the lung mets should be dealt with a bit of a caution. But for bone mets, we can go to higher doses.
So there's a question from Dr. Babar that, hello, do we need to know about the doses exactly in our exams setup? Let me answer this question. As we are talking to highly expert person, that's why we are going into nitty-gritty of the details, and we are asking about his personal experience. In exam, you are expected to know about high doses and low doses. That's more than sufficient, I think so. But sometimes you can have a question like that in MCQ or ECQs in your paper, so that that would ask you need to give an exact answer for that. So why not to know about the doses of the radioactive iodine therapy? I think it's important.
As I mentioned earlier, in benign diseases, we give 15 to 10 to 30 millicurie most of the times in benign diseases of the thyroid, like in diffuse toxic goiter, in solitary toxic nodule, in multinodular goiter. In remnant ablation, we go from 30 to 100 millicurie. In dealing with the localized neck disease and remnant, we go 150 millicurie. For example, if you have got lung or bone mets, we go beyond 200 millicurie. This is an average. These are average doses. If I don't want to make your life more miserable by calculating how do we calculate it, so I think this is an adequate explanation for this.
I think everyone should write it down.
I'll share with you
Maria, any question left behind?
Sir, I think we are done.
I left most of the time for the discussion because I thought that it would be very interesting to hear from the fellows, from my younger colleagues. They would be having a lot of questions. So I hope we are done with our time as well.
Thank you, sir. It was a really nice session. We thoroughly enjoyed and learned a lot.
Dr. Akif?
Yeah, I would just
thank you, Dr. Akif.
Yeah, I would just thank you, Professor Zareen, for taking me on board. I'm very much honored, and your team is wonderful. And you have gathered quite interesting audience. You have gathered followers who are following your discussions and your these Zoom meetings. And I'm very much impressed by the interest of all the participants. I tried my best to communicate my message in a simpler form, because nuclear medicine is very much about the mathematics and physics part. So I tried to make it as simple as possible for my colleagues of surgery who spend most of their times in the operation theaters and in the wards. So may Allah bless you, and thank you for giving me this opportunity. I would also extend my support to your future activities as well. So I think if your forum wherever needs me, you can ask me and I'll be there for my inputs, whatsoever they are, for your cause and for this noble cause, I would say. Thank you. Thank you, all of you. Thank you for
Thank you, sir, for this offer. Inshallah, we will involve you very soon. Thank you, everybody, for participants and hosts. Thank you very much, and see you again, inshallah, in the next session.